Hello, and welcome to the Parkinson's Foundation's program, Beyond the Diagnosis, Managing Changing Symptoms. I'm Melody McLaughlin, Senior Community Program Manager for the New England chapter of the Parkinson's Foundation, and I'm so thrilled to be joining you today for this very special program. I also want to welcome our families in Connecticut who are joining us today for our first Connecticut program. For those of you who are newer to the Parkinson's Foundation, welcome. We are the nation's leading community for people with Parkinson's, the people who love them, and all those who are working to end the disease. It's with our presence in communities across the country and the globe that we believe in a promise of a cure and a better life today for those impacted by PD. The urgency of our mission really translates into what we do. To achieve our mission, we pursue three goals: ensuring better care for everyone for today, understanding Parkinson's through research for tomorrow, and educating and empowering the Parkinson's community for us all. We provide free resources, including our website, parkinson.org, educational book series, webinars, podcasts, our hospital safety kit called Aware and Care, our newly diagnosed kit, and of course, our toll-free helpline, 1-800-4PD-INFO, which is staffed by Parkinson's specialists. On the research front, we invest more than $10 million annually to study Parkinson's, what causes it, how to treat it, and ultimately how to cure it. I'd like to highlight PD Generation, which is an initiative that offers genetic testing and genetic counseling at no cost for people with Parkinson's. We are thrilled to announce that PD Gene has launched its next step, a genetic test that can be done at home. To learn more, visit parkinson.org/PDGeneration. So how are we connecting with our communities? Well, your being here with us today is a prime example of that. It's really through our centers of excellence, our local PD experts like Dr. Christine Kim, who's joining us today, volunteers, advocates, and staff across the country that we bring people together to educate and empower those impacted by Parkinson's. We also connect with our Parkinson's communities through our nationwide Moving Day events. Since 2011, our Moving Day walks have raised more than $27 million to support research, our Centers of Excellence networks, and provide education and resources and programs across the country. We are very excited at the New England chapter to share that we're bringing Moving Day to New Hampshire on May 22nd, 2021. To learn more about our New Hampshire Moving Day, please visit movingdaywalk.org. And always looking for ways to keep the PD community connected, the Parkinson's Foundation has been providing weekly educational and wellness programs in a virtual format through our PD Health at Home series. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible so that you can enjoy Mindfulness Mondays, Wellness Wednesdays, or Fitness Fridays by visiting parkinson.org/PDHealth. And today's program was made possible by the support of our sponsors. Today, we thank our bronze sponsors, Acadia and Lundbeck. We invite you to learn more about our program sponsors by visiting our virtual exhibit hall at parkinson.org/New England/chapter-supporters. And with that, I am now delighted to introduce today's speaker, Dr. Christine Kim. Dr. Kim is a fellowship-trained neurologist specializing in the practice of movement disorders on faculty at Yale School of Medicine. She received her medical doctorate at Columbia University and completed her residency training in neurology and fellowship training in movement disorders at Columbia University Medical Center. She treats patients with all types of movement disorders, including Parkinson's and atypical Parkinsonism, tremor, ataxia, and has particular interest in the pathology and treatment of dystonia. Her practice includes the use of botulinum toxin injection and deep brain stimulation for the treatment of movement disorders. Please join me in welcoming Dr. Kim.
Thanks very much, Melody, for that kind introduction. It's a pleasure to be here today and to see so many participants here to learn more about Parkinson's disease. So I'll mention that my research is supported by the Dystonia Medical Research Foundation, not directly relevant to today's talk, though. And so today we will be focusing on mid-stage or mid-stride Parkinson's disease. And so by this we mean Parkinson's disease that has been going on for a few years. And with the natural progression of the Parkinson's, patients at this point may be starting to notice symptom progression and encountering some common challenges such as motor fluctuations, dyskinesias, dystonia, and freezing of gait. In addition, though, we really want to focus on some of the strategies and treatments that we have to address these problems, and also to learn when it's appropriate to expand your Parkinson's care team and to seek out rehabilitative treatments and other healthcare services to kind of supplement your treatment plan. And so first, because we're meeting virtually today, I wanted to have a better understanding of our audience today. Oh, and I see lots of people answering already before I'm even reading my poll out loud. So this is great to see. Okay, perfect. So I see that about 2/3 of our audience today are patients with Parkinson's disease. Almost a third are caregivers of somebody with Parkinson's disease. And then other roles in Parkinson's disease care as well are kind of represented in our audience today. So I'll try to gear my talk to your needs as well. Okay. And although we'll be focusing on kind of this mid-stride Parkinson's disease, I wanted to take a brief step back and review some of the cardinal features of Parkinson's disease at all stages. And some of this may be familiar to all of you. I know often Parkinson's patients are extremely well educated about the disease. The cardinal features that we see in Parkinson's disease include resting tremor, so tremor of the limbs or neck that can occur specifically when that part of the body is relaxed or at rest. Bradykinesia of movements, so slowness of movements that can occur in the face, limbs, or trunk, affecting facial expression, everyday tasks such as buttoning buttons or handwriting or walking. Rigidity, so stiffness of the limbs or the trunk, and postural instability or difficulty with balance. And so although these are the cardinal features of Parkinson's, it's important to note that the features may vary actually quite a bit between patients. For example, some patients may have no tremor at all, and others may have tremor as their most prominent symptom. And all of this is normal within Parkinson's disease. So Parkinson's is a disease that changes over time. And as neurologists, we think of it divided into 5 main stages, depending on sort of at what stage the progression is at. In the first stage of Parkinson's, symptoms affect only one side of the body, and patients may remain in this stage for several years or longer. Eventually, the Parkinson's symptoms do go on to affect both sides of the body, at which time we consider stage 2 to have started, not yet affecting balance. As time goes on, patients may begin to notice a little bit of trouble with balance, at which time we consider them to be in stage 3. In stages 4 and 5 of the disease, patients may require a little more assistance with daily activities as well as with walking. And although the underlying causes for Parkinson's disease are not totally understood at this time, we know that in Parkinson's, the cells in the brain that produce the brain chemical dopamine are injured by the Parkinson's disease. And this leads to low levels of dopamine in the brain and in the body. And this chemical is important particularly in motor pathways of the brain. So pathways of the brain that control and regulate our movements, explaining why we see these effects on motor performance in the disease. Dopamine is also important in other brain pathways and other parts of the body, including the gut. So patients might notice symptoms involving the belly, such as constipation in the disease. And so because the disease fundamentally causes a drop in dopamine level, the treatment strategies for Parkinson's disease rely on acting on that dopamine pathway in the brain. And we have three main pathways to do this. The first pathway involves boosting dopamine levels, so boosting the level of dopamine that's already produced in your body. And we have two main strategies to do that. We can do this by blocking the breakdown of dopamine, so blocking the chemicals in the body that naturally break down dopamine, or we can stimulate the release of dopamine. And I'll discuss some of these medications that can perform these functions a little bit later. In addition, we can stimulate the dopamine pathway directly by stimulating the receptors in the brain for dopamine. And the class of medications that achieve this are known as the dopamine agonists. Agonist is basically a word meaning imitator. So chemicals that sort of imitate the effect of dopamine. The third main class of medications available for the treatment in Parkinson's involve direct dopamine replacement. And this medication is known as carbidopa-levodopa, which is really a mainstay of the treatment of symptoms in Parkinson's disease. In this medication, there's two components, the carbidopa and the levodopa. The levodopa is actually the active component of the medication. That gets directly converted in the brain into dopamine. And the carbidopa is actually there just to help the medication work more effectively by blocking the activation of the medication in the belly where we don't want it to be working and allowing more of it to get up to the brain. And this effectively allows direct dopamine replacement and can result in very significant relief in a lot of the motor symptoms in Parkinson's disease. And so I wanted to understand among the patients in the audience, how many people are currently taking levodopa? It's looking like by far a majority. So we have 82% of you are currently taking carbidopa, levodopa, 18% not yet taking that medication. And so that's helpful for me to know. And targeting maybe more those of you who are not yet taking carbidopa, levodopa, perhaps you are already taking other medications that I had mentioned earlier. But in understanding when is the right time to initiate treatment, it's important, as in all Parkinson's care, to note that that decision is really individualized to each patient. So kind of commonly, if a person is starting to be affected in their ability to perform the tasks in their daily life, such as getting dressed, using their hands as they need to, and often if they're having trouble with walking, then we strongly consider starting carbidopa, levodopa, but there's a lot of variability in when we choose to actually start the medication. Patients, once they begin taking carbidopa, levodopa, by and large, I would say the majority notice a significant improvement in their motor symptoms. And in some cases, patients might notice changes in their symptoms with each dose of medication. And they may notice that when they take the medication, they feel it starting to go to work. They feel their body working better. They feel better overall. We refer to that as an on state. The medications seem to be working well. Conversely, at the end of the dose, they may notice that the medicine seems to be wearing off. They might notice that tremor or stiffness or other symptoms seem to come back, and especially if they're late taking a dose, they might notice these so-called off symptoms. So though that on and off state can become more prominent in later stages of Parkinson's disease. Not all patients actually notice an on or off state. Some people have kind of more of a background effect that doesn't seem to fluctuate too much. And all of that, again, is normal for Parkinson's disease. Another important point is that these motor symptoms can remain very well controlled without any complications with medications for several years and kind of stay in this honeymoon period. As Parkinson's disease progresses, we know that less dopamine is produced by the body and the brain. And together with that, the brain's response to dopamine can actually change. We think that the receptors in the brain for dopamine can become a little bit more sensitive to changes in dopamine levels as Parkinson's disease progresses for a few years. And together with that, patients might start to notice corresponding changes in their symptoms and in their medication response. And that will kind of be the bulk of the talk today, is focusing on those changing symptoms. But one very important point is that these changes can be very effectively managed with adjustments to medication and with other treatment, and they're a completely normal part of the progression of Parkinson's disease. So common issues that can arise in this mid-stage or mid-stride Parkinson's disease include motor fluctuations. And so by this, I mean fluctuation in the motor symptoms that seems to occur relative to medication doses. And the main issues that occur with motor fluctuations are that the medications can seem to wear off. They just seem to stop working. And this can sometimes occur more abruptly and more dramatically than in the early years of medication use. And the second main issue that can occur with motor fluctuations is the occurrence of involuntary movements that are actually related to the medications themselves. And these can be typified by either dyskinesias, which I'll discuss more in detail later, but are excessive repetitive movements of the body in response to changes in dopamine levels, or dystonia, which is an excessive sustained muscle contraction, also can be seen as a result of fluctuation in dopamine levels. So I'm wondering, among the patients today, how many of you have experienced wearing off dyskinesias or dystonia? Okay, so this is very helpful. I see about 90% of you actually have noticed wearing off with the medications. About half have noticed dyskinesias at some point, and nearly half have noticed dystonia. And that's not at all uncommon, that the total would add up to more than 100%. Often there's overlap in the symptoms that people experience with motor fluctuations. So I'll begin by describing wearing off and some of the strategies that we have to improve wearing off episodes. So wearing off, it sounds like 90% of the patients among us are familiar with it, but for those not familiar, we mean recurrence of the Parkinson's symptoms as the dopaminergic medications wear off. And wearing off can actually result in the recurrence of motor symptoms, so the stiffness, slowness, and tremor at the end of the dose, but can also include non-motor symptoms actually. So patients might notice sensory changes in one part of the body, like tingling, a feeling of general restlessness, sweating spells, or just feeling generally unwell or fatigued at the end of the dose. And over time, the fluctuations and the wearing off may become more frequent or more noticeable as Parkinson's disease progresses. So we have a number of strategies for addressing wearing off. They fall into two main groups, essentially. One main strategy is to try to avoid the wearing off episodes altogether. And the second is to actually actively treat the wearing off as it occurs. So the first main group, avoiding off states. Actually developing an understanding of any recurring patterns in the wearing off episodes can be very crucial in helping us to better adjust and better time the medications for each patient. And you'll see that this is going to be a very recurring theme throughout my talk with each of these symptoms. So often we will recommend that a patient keep a symptom diary in order to track the timing of the symptoms relative to their medications. And then this really allows us to make tailored adjustments to Parkinson's medications to better address particularly problematic times of the day. In some cases, we can also adjust the timing of medications relative to meals if we find that wearing off tends to occur in correlation with the timing of meals. This is because high protein or protein in the diet actually interferes with the absorption of levodopa. And this does not mean that we should avoid protein in the diet altogether by any means, but sometimes we can adjust the timing of meals. For example, avoid high protein meals like poultry or meat or eggs in the 30 minutes prior to taking the levodopa. So one main category of medications that can help to avoid the off state are those that allow us to basically increase the duration of medication effect. And so this brings us to that category of medicines that I mentioned, which actually prevent the breakdown of dopamine. And these fall into two main categories. So I put the chemical names and then the names of the actual medications. And the main point here being that we have two main groups of medications that help to prevent dopamine breakdown. And each of these groups, so the top row and the bottom row, act on two different enzymes that occur naturally in the body and serve to break down dopamine naturally. So the first group in the first row are the COMT, C-O-M-T inhibitors, which include entacapone and newer to the market opicapone. And these effectively serve to extend the effect of levodopa to make it last longer by keeping more of it around for longer. Together with that, some patients might notice worsening in their dyskinesias as the levels of levodopa build up in the body, but we have many strategies to address that if that does occur, so which I'll get into in more detail later. The second main category in this group of medications are the MAOB inhibitors. So they block another enzyme that breaks down dopamine, and these include rasagiline, selegiline, and newer to the market safinamide. And these, again, effectively extend the life of levodopa and make it last longer, so extend the duration of symptom benefit as well. In addition, there's a question in the Parkinson's field about whether there might be a neuroprotective effect with the MAOB inhibitors. So whether there might be an effect of slowing down symptom progression slightly in Parkinson's disease. And we don't have a clear answer for that based on the science yet, but because of this possibility, we kind of factor that in, and often we'll start these medications, favor these medications because of this possibility of a neuroprotective effect. These medications, similar to the COMT inhibitors, may worsen dyskinesias as levodopa builds up in the body. In the case of selegiline, some patients may notice insomnia, and so we usually recommend dosing that particular medication in the morning to avoid effects on sleep. In patients who do have a lot of fatigue during the day, actually, we can sometimes capitalize on this side effect and use it to our advantage to help people wake up a little bit during the daytime. The MAOB inhibitors, when taken at high doses, can have an interaction with antidepressants, which can be serious. So it's actually very important with these to stick to the prescribed dose and to always make sure that your neurologist and psychiatrist are aware of what medications you're taking. In some cases, these medications can be limited by cost, but we always have strategies, including appeals to the insurance and things like that, that can help with that. The other main strategy in avoiding off states include a family of longer acting forms of levodopa. So forms of levodopa that are actually designed to last longer in the body. So this includes the carbidopa-levodopa controlled release formulation, which has the advantage of a slower release into the body than the regular immediate release carbidopa-levodopa. The immediate release being really the standard medication that most patients are started on as their first form of carbidopa-levodopa. And this slower release helps with wearing off episodes. Similarly to the prior slide, patients might start to notice a little worsening in dyskinesias in some cases, but we do have strategies for dealing with that. And important to know that sometimes the dose of controlled release might have to be slightly increased relative to the regular release, but very easy for us to make that adjustment. Slightly newer to the market in the last 5 years or so is the carbidopa levodopa extended release capsules, known currently by the trade name Rytary. And the idea with this medication is that it contains both short and long-acting levodopa formulations together in one capsule. So helping to get the benefit of both a long-acting, long-duration effect of the medicine, but also to get a good immediate effect when the medication is first taken. So again, can help with the wearing off, but also still getting a good immediate effect. Again, this long-acting formulation in some cases can worsen dyskinesias. And then because it's currently available by trade name and not generic, can be limited by cost. The company does have a patient assistance program, though, that can be helpful in many cases. And then the final medication in this group of medicines that can help to avoid the off state is an add-on medication known as istradefylline, or by the brand name Norience. And this medication works a little bit differently. It does not directly activate dopamine in the brain, but it actually works by blocking one of the braking mechanisms on dopamine in the brain. So it sort of knocks out adenosine, which normally acts as a brake on dopamine pathways in the brain. And so effectively, patients can get a little bit more dopamine activity in the brain. And we know that this medication in some patients can slightly decrease the daily amount of time in the off state. And side effects here, again, can be similar to the dopamine agents I mentioned before, including dyskinesias, sometimes hallucinations, as well as in a few cases, impulse control disorders. And these are changes in behavior that we can sometimes see with both dopaminergic medications as well as with the Norience, where patients can become impulsive, develop difficulty with gambling, spending a lot of money, or even develop changes in their sexual behavior. So although these are rare, we always like to screen for these as your neurologist and to be very aware of them, because we take these changes in behavior seriously if they do happen. Now, the other main strategy for dealing with wearing off episodes, if we can't prevent them entirely, we have medications which are available to actively treat you when you go into this off state. And so these are kind of rescue medications. And the first main category of these are shorter acting forms of levodopa. So the first one I included here is the carbidopa levodopa immediate release. And this again is the regular carbidopa levodopa that most patients are initiated on as their first form of carbidopa levodopa. When this formulation is chewed, crushed in the teeth, and taken with a lot of water, it can actually help to boost how quickly it kicks in, and can be used as a rescue medication, particularly by taking it that way. And of course, it's very easy to use, and patients are often very familiar with this formulation. So I often use this as my first line, first on the list if patients are having off episodes. Side effects with this, I put in parentheses only because these are really seen with any form of levodopa, but can include nausea, low blood pressure, dyskinesias, or hallucinations. Not really more so with this form than any other form of levodopa. We also have available a dissolving formulation of carbidopa levodopa, so one that's actually placed directly under the tongue and dissolves there. It's very easy to use, and one of the benefits with it is that it's absorbed a little bit more quickly than the kind that you chew and swallow. This is partly because actually Parkinson's disease, as I mentioned, does have some effects in the belly. And one of those effects can be to slow down how quickly your stomach can work and absorb medications. By placing the tablet directly under your tongue, you're kind of bypassing your stomach and getting the medication into your bloodstream a little bit more quickly. Side effects with this are the same as for the immediate release carbidopa levodopa. And then the third main form of rescue levodopa that's available is newer to the market. And this is actually an inhaled form of the medication, an inhaled powder available currently as the trade name Inbrija. And again, this is absorbed more quickly into the system than the immediate release pills, and so can achieve quicker kicking in for some patients. Things to note with this form are that it is inhaled as a powder through an inhaler, and so can cause a little bit of irritation in the breathing. So we avoid this medication in people who have underlying lung disease. In addition, because it's inhaled through an inhaler, it does require a little bit of motor coordination to actually administer. So some patients have told me they feel that when they are actively in an off state, they don't find it as easy to use as putting a pill in the mouth, just in terms of the actual movement that's required. The final medication that's available for actively treating the off states is an add-on medication. And this is the medication apomorphine. And this falls into the category of medicines that are kind of dopamine agonists or dopamine imitators. So they act on that dopamine pathway, but without actually adding more dopamine directly to your system. Apomorphine is available in an injection form or in a more recently actually in an under the tongue formulation. So a tablet that goes under the tongue and dissolves. And both of these formulations can have a very fast onset of action. So can kick in more quickly than especially the oral forms, the forms of pill forms of carbidopa levodopa that go through the stomach. With these medications, we actually can see a significant number of patients who experience low blood pressure with the medication, just related to the slightly different chemistry of this medication. And so we do like to monitor the blood pressure closely when we first start it, and may even consider avoiding the medication if a patient has low blood pressure to start with. But usually with close monitoring of the blood pressure, we can get around this issue. Similar to the other medications, can see worsening in dyskinesias, some nausea, hallucinations. With the injectable form in particular, it is an injection, so comes with the discomfort that could be associated with that. May also be a little difficult to actively administer during actual off episodes, but caregivers may be able to assist with that. And patients in some cases can experience some skin irritation at the injection site. And I wanted to mention that we do also have other mechanisms for carbidopa levodopa delivery that we can consider if these less invasive, non-invasive medications that I've already mentioned are not effective enough. And so the main option here is a carbidopa levodopa intestinal gel known by the trade name Duopa. And this has the benefit of allowing continuous infusion of a carbidopa levodopa gel. And so the continuous infusion avoids some of the peaks and valleys that can come with taking a pill form of the medication throughout the day. One very important thing to note, though, is that this has to be delivered through a tube that's has to be inserted surgically, actually through the wall of the abdomen directly into the small intestine. So it is significantly more invasive than the other modes of delivery that we've mentioned. So the downsides being that it does involve surgical placement with a surgeon of this special tube. There is the risk of low blood pressure that requires monitoring. So we see more low blood pressure than with the pill forms of carbidopa levodopa when first starting the medication, just meaning that we need to monitor the blood pressure carefully when we first start this. Patients may also experience the nausea and dyskinesias that can be seen with other forms of levodopa. So although invasive, this for some patients, this can be deliver a good advantage over other pill forms of medication, but just keeping in mind that we would consider this only after these less invasive methods of delivery had not been effective enough. And One other main category of intervention available to us in Parkinson's disease that I wanted to mention is deep brain stimulation surgery. And this topic is essentially large enough that it could take up its very own 1 hour talk. So I will not go into detail about it today, except to mention that it may be an option for some patients whose symptoms are not adequately controlled with medication adjustments. And patient selection for deep brain stimulation surgery is actually very important. We always carefully screen each patient's history in terms of what symptoms we are trying to improve, what side effects they might have, and also what other medical problems or complications they might have. And all of those factors are weighed very carefully in trying to identify which patients are more likely to benefit from the surgery. The procedure involves surgical placement of very small wires or electrodes into specific brain structures, and then actually a second surgery to insert a pacemaker battery into the chest wall. And then these devices are used to deliver very precise electrical stimulation constantly to very specific brain areas. And through the delivery of that stimulation, we change essentially the brain electrical activity and can achieve improvement of motor symptoms, at least as well as levodopa. And the advantage being that because that electrical stimulation is delivered constantly, we can achieve this without fluctuation in symptoms. Also, that programming is carefully adjusted over time, over years, to target changes in symptoms as they occur. Now, another category in motor fluctuations that can come up, as I mentioned, are these excessive movements that occur as a complication of therapy. And here again, I mentioned dyskinesias is a large group of these involuntary movements that occur. Sounds like about half of you among the patients have experienced these today. For those not familiar, by this we refer to involuntary repetitive movements, which can occur actually in any part of the body, the face, trunk, or limbs. And these movements are a consequence of exposure to dopamine medications in patients with Parkinson's disease. One important thing to note with these movements is that they are not harmful, and they actually may not bother the patients themselves in any way. Patients may not even be aware of them, but they can cause discomfort, especially if they occur very repetitively in one part of the body. And so we always as your neurologists, like to be aware of these and to come up with strategies for improving them if they become, actually before they become severe. So the first strategy here is trying to avoid the dyskinesias. And similar to the wearing off episodes, it's important to have an understanding of the timing of the dyskinesias and to identify any patterns in the timing. This is because dyskinesias actually can occur either in the on state or the off state or both. And this can make them tricky to manage because sometimes the strategies trying to improve one of those might actually worsen dyskinesias in the opposite state. So we like to have a good understanding of whether the on or the off dyskinesias are happening. And again, keeping that symptom journal can be very helpful to your neurologist to understand this. If we do develop a good understanding of the pattern, we first start by adjusting the timing or sometimes dosing of your dopaminergic medications. For example, if you had a lot of dyskinesias in the evening, we might slightly decrease the dose of that medication if they seemed to be associated with buildup of the dopamine levels in your system over the day. In the case of dyskinesias that occur as the medicines wear off, we might also consider some of these strategies that I mentioned to extend the duration of your dopamine medications. In addition to changes in your dopamine medication regimen, we have one main medication available to directly treat the dyskinesias themselves, and this is amantadine, which actually has several benefits in Parkinson's disease and can help to improve some of the cardinal symptoms of Parkinson's itself. But in mid-stride Parkinson's, amantadine is most often used, I would say, to try to decrease the severity or frequency of dyskinesias. Possible downsides with this medication include it can cause skin changes, so sort of a skin rash or leg swelling in some patients. These are not dangerous, but they can be cosmetically bothersome. So we do like to keep an eye on these and be aware of them if they happen. And in addition, particularly in patients who have hallucinations, amantadine can worsen these. So we always like to keep a very close eye on any hallucinations and might consider being extra cautious with this medicine if somebody already has a lot of hallucinations, kind of going into this. Another excessive movement that can be seen as a consequence of fluctuating dopamine levels is dystonia. And sounds again like almost half of you have experienced this and are aware that dystonia is defined as an involuntary excessive muscle contraction affecting specific muscles in the body. And this again can occur in any part of the body, actually the face, the trunk, or the limbs. Common examples in Parkinson's patients include curling of the toes, cramping of the leg, and turning of the foot, kind of twisting of the foot. And more often than not, patients are aware if they develop dystonia, as it can often be uncomfortable or painful. Similar to the other symptoms that I've mentioned, our first strategy is to try to avoid dystonia in the first place. And dystonia can also occur in either the on state or the off state. So again, developing an understanding of any pattern in the timing is very helpful. So again, your symptom journal will be helpful for your neurologist. And then we can use that information to adjust the dopaminergic medication dosing or timing to target any patterns that emerge. Dystonia can also be directly treated, and I would say should be directly treated if it does not improve with other medication adjustments because of the discomfort that can be seen with it. So the first line treatment for dystonia is actually botulinum toxin injection. And botulinum toxin effectively injections at very microscopic doses can effectively very slightly weaken affected muscles. So in the case of dystonia, we use that to our advantage because we inject it into muscles that are contracting too strongly and try to take the edge off of the dystonia without causing functional weakness in that muscle. And the benefits with this are that because it's directly injected into specific muscles, we don't see much in the way of systemic side effects. So nothing like sleepiness, fatigue, or things like that. Downsides with the injections, as we are effectively trying to slightly weaken the muscle, in some cases, patients might notice functional weakness, feeling weakness of that part of the body. That is temporary if it occurs as the medication does wear off after 3 months, and the injections do have to be repeated every 3 months for that reason. The injections require special training, so they're not available in all areas, but throughout the state of Connecticut, there's multiple providers and centers who can provide these injections, and your movement disorders doctor can help you to identify those providers. In addition to botulinum toxin injection, there are a couple of oral medications that are known to improve dystonia symptoms. These include a medication known as trihexyphenidyl, as well as clonazepam. Downsides with these medications are that they can be limited by side effects. So they are pill medications that have to be taken into the whole body. And in order to achieve the level of improvement in the dystonia, we often have to go to higher doses with which patients can sometimes notice the sleepiness or feeling fogginess in their thinking. So we often start first with botulinum toxin injections if we feel that the muscles are good candidates for the injections. Finally, one final feature in mid-stride Parkinson's disease that I wanted to mention is freezing of gait. And these are defined as very abrupt, sudden episodes disrupting walking. They're sudden episodes of inability to move the feet forward when attempting to walk. So patients describe sometimes that their feet just feel like they're stuck to the floor, that they're glued down and do not want to come up. And freezing of gait does not happen in all patients by any means, but when it does occur, it can have a very significant impact on quality of life. And it does increase fall risk because the feet will abruptly stop kind of moving when a person's walking, leading to falls at times. And so because of this, we take freezing of gait seriously and like to stay on top of managing it and minimizing it. The cause for freezing of gait is unknown. We don't understand why some patients develop this and others don't, but we do know that several different brain pathways are involved. So the sort of anatomy of it is complex. And here again, freezing of gait can occur either in the on state or the off state. And so identifying any patterns is very helpful again. And so keeping that symptom journal, cannot get away without keeping your symptom journal. And if we find that freezing of gait is tending to occur in the off state, we again will adjust the dopaminergic medications using the strategies that I mentioned to kind of improve that. And freezing of gait is actually very responsive to behavioral interventions, so kind of physical therapy interventions. And so because of that, physical therapy is a real mainstay of treatment in freezing of gait. And so essentially every patient that I have who develops freezing of gait, I will send them to get physical therapy. And strategies that help with freezing of gait actually involve shifting attention away from the walking in some way. And we can achieve this by having patients shift their weight from one to the other when walking, which can sometimes help to break the cycle of freezing, shifting their attention to another task or movement, perhaps involving the hands, using visual cueing, such as lifting the feet over markers on the floor, like lines on the floor, or using a laser pointer. Auditory cueing is also effective in breaking freezing of gait. So marching to music can be helpful. I had one patient who kept an iPod on at all times and had Bolero playing, which he claimed was the most effective in helping with his freezing. In addition, avoiding triggers can be effective in actually avoiding the freezing. So avoiding tight spaces like revolving doors, avoiding rushing, and always taking wide turns, not trying to turn in narrow spaces, which can provoke freezing. In addition, I wanted to mention that across the board in Parkinson's disease, so really in the management of all of the symptoms that I've mentioned today, regular exercise is very critical in Parkinson's disease. And this is because we know that it improves symptoms in Parkinson's, but it also, beyond that, slows the progression of disease in Parkinson's. And we know this both from studies in patients with Parkinson's disease and also animal studies of Parkinson's disease. So essentially, your Parkinson's doctor will always be checking in with you about what you are doing for exercise. And there's many actually kind of Parkinson's specific exercise programs available now, including big physical therapy, Parkinson's exercise classes, Parkinson's boxing classes, and Parkinson's dance. And many of these are available online currently during the pandemic. Actually, any form of exercise is effective in slowing progression in Parkinson's and improving symptoms. So it's most important that your form of exercise be safe, number one, but enjoyable, because we want you to be continuing with this form of exercise for years and years. If you enjoy it, you're more likely to stick with it. So the right form of exercise is different for every patient. Just important that you be consistent with it. I would say at least 3 to 4 times per week, but every day would be even better. And so as you've seen here, really the management of your Parkinson's involves a whole team of experts. So you are at the center of that team. Your movement disorders neurologist is one kind of member of your team, but physical therapy, occupational therapy, and speech therapy as well, which I hadn't mentioned before, very effective in improving your symptoms. Other physicians may be added to your care team as your symptoms change over time. And it's always very important for all of your providers to be aware of your diagnosis and for them to be in contact with each other. For example, some medicines can actually worsen your Parkinson's symptoms. And so we always like to avoid using those medications, obviously. Commonly, as Parkinson's changes over time, psychiatrists or psychotherapy can be helpful. Urology specialists can be helpful in managing urinary symptoms, and an internist can be helpful in managing severe fluctuations in blood pressure. So just to summarize today, I know we've talked about a lot, but to emphasize, motor fluctuations are really a very normal part of mid-stride Parkinson's disease, and we have many medications that are available to improve the duration of symptom control or to get faster symptomatic relief. Understanding any recurring patterns in the timing of your symptoms can really help to tailor your treatment plan. And very commonly, a combination of all of these medications that I've mentioned is used in mid-stride disease, and that's really to tailor the symptom control to your specific symptoms. Any side effects that occur with these medications can also be effectively managed with adjustments or add-on treatments. And physical therapy and exercise can have significant effects in improving all of these symptoms that we've talked about today. So thank you all so much for listening. And I think I've gone a little bit over, but we do have time for questions, I think, as well. So I know a lot had been coming in.
Yes, we do. And thank you, Dr. Kim, for sharing this fantastic information with us today and for your insightful presentation. A lot of wonderful information. And if you are looking for the archived version of this, you will find it at parkinson.org/YouTube and also in an email that'll be coming to you. So we did receive a lot of great questions from our web audience today.
Yes,
so we'll take some time to address those. And I want to mention too, because of the volume received, if we don't get around to your question, please consider calling our helpline at 1-800-4PD-INFO, or also please do speak to your personal movement disorder neurologist who knows you best. Let's see some of our questions today. How do you deal with a patient who does not follow the movement disorder neurologist orders? My loved one with PD has been diagnosed 13 years now, is having some cognitive problems, dyskinesias, and can't tolerate amantadine. Now what?
Okay, yeah, that's a very, I think, insightful question, and one that, does come up. I think actually the most important thing here is probably understanding why the patient is not following the recommendations. And the reasons for that can be very variable, actually. So I think probably most commonly in my experience, a patient might be experiencing side effects with the medication that they may have been a little shy to bring up, or or that they haven't necessarily correlated with the medications, and might be limiting their use of the medications for that reason. So in that case, I like to, first of all, develop that understanding, but also to emphasize that the side effects are quite treatable, and that we have good strategies for dealing with them. We have so many strategies that I didn't even have time to get into all of them today. I think that question also mentioned this possibility of a component of cognitive decline, and I don't know whether that's factoring into why this person has not been taking their medications, but that is something that we can see in some patients as Parkinson's disease progresses, is a little bit of effect on cognition and memory. And I think, first of all, of course, understanding that and delineating that is helpful. But I think if that is the case, we have many good strategies for helping with the memory trouble itself, and perhaps even plugging in the patient with another team of experts, but also using a schedule or a timer or pill boxes, or having an assistant to help them take the medications as they're recommended and scheduled. All of those strategies can kind of be helpful.
Great, thank you so much. The next question here is, to what extent is the progression of Parkinson's predictable and the same for everyone? And how much is variable with the potential for lesser or more milder symptoms over the years?
Yeah, that's a great question. And so the short answer is that the progression of Parkinson's disease is quite variable, but that in general, the progression, I always like to mention the progression is real, but it's not something that happens quickly from week to week or month to month. In Parkinson's, it's really progression over years and years and decades, and that patients can maintain a really excellent quality of life for decades in spite of having the disease, especially because we have so many very effective treatments for the symptoms. One thing that I think I mentioned in my exercise spiel, but I want to just hit here again, is that regular exercise, we really know that that slows the progression of Parkinson's disease. We actually don't have a medication that yet, we're working on that, but we don't have a medication yet that is proven to do that, but good old fashioned regular exercise slows that progression. And I mentioned we know that from studies that have been done across large numbers of patients with Parkinson's. I will say I definitely see that in my own patients with Parkinson's, the patients who are able to really stick with a enthusiastic exercise regimen. I can see that their symptoms are progressing more slowly, and that the effects of their symptoms are less impactful to them.
Great, thank you. And sort of a similar question in terms of progression.
Mhm.
Let's see here. Can you discuss the progression differences between a tremor or non-tremor dominant PD?
Yeah, that's a very well-educated question that our audience member is asking. So I mentioned briefly when I was talking about the cardinal features of Parkinson's that the symptoms can vary between patients, and that is quite true across the board. But in addition to that, we actually in larger groups of patients with Parkinson's, we see that there seem to be several subtypes of Parkinson's. So not all Parkinson's is the same. People that have very prominent tremor as their first symptom, so-called tremor predominant disease, we think progress slightly more slowly than patients that have a Parkinson's disease without tremor, or atremulous Parkinson's disease. However, I don't want people who don't have a lot of tremor to feel discouraged, because one issue is that it's actually very difficult for us to compare the tremor predominant type and the people without tremor, because different people notice their symptoms at different points in time. So we don't always exactly know, in fact, when a person's Parkinson's disease had first started. But we do think that there may be these slight differences in the tremor predominant disease.
Great, thank you. And we have quite a few questions here on diet and nutrition. And just sort of speaking more generally, trying to combine these questions here. Are there any foods that lessen PD symptoms, or is there a regime people should consider before taking their medication?
Yeah, so there's not any specific diet or food that improves Parkinson's symptoms. However, in general, I always recommend having kind of a well-balanced diet. Another kind of issue in diet that comes up quite commonly is that constipation, I mentioned, can be very common as a direct consequence of Parkinson's disease. So really trying to build a lot of fiber into the diet with whole grains, lots of vegetables, and whole fruits as well can be really helpful in improving quality of life overall. And I had mentioned that sometimes there can be a little bit of a competition between protein in the diet and the Parkinson's medications, specifically levodopa, really. And so again, I'll just reiterate that avoiding kind of very high protein meals directly before the levodopa dosing can be helpful in sort of letting the medicines work better. In addition, my final point on this is that because the stomach can be slowed down by the Parkinson's disease itself, sometimes patients find that if they kind of convert gradually from having the traditional 3 large meals per day to having multiple smaller meals per day, it's a little bit easier on their stomach, and they sometimes find that their medications work a little bit more smoothly if they kind of work that way. But the right answer is different for everybody. You kind of have to find what works for you.
Great, thank you. And I think we have time for maybe 2 more questions. We have a lot of great questions here. I have noticed that my current dosage of carbidopa levodopa does not improve my motor skills as it once had. I feel like I may have to stop playing tennis and skiing. what is usually the next step in medication and how much improvement will I see?
Okay, yeah, that's a great question. And I'm very glad to hear that you've had improvement in your motor symptoms with the carbidopa levodopa. We have a couple of strategies for dealing with that kind of feeling of feeling like that dose of medication is not quite taking its effect as strongly as before. In general, one strategy that I did not yet mention is actually increasing the dose of the medication as a natural part of the progression of Parkinson's disease. I mentioned that dopamine levels in the brain do kind of decrease gradually over time. And so sometimes as disease progresses, we need to increase the dosing of the levodopa slightly to compensate for that. It will depend a little bit on your specific symptoms and actually your examination findings. So I would say your neurologist will be able to better help you make tailored management changes. But other than the strategies that I mentioned, that can be helpful for that particular problem, sometimes increasing the actual dose.
Great. Thank you, Dr. Kim. And to wrap up, I just wanted an opportunity for you to share any final thoughts after these questions you received, any additional notes before we wrap up here.
Yeah, maybe I'll just mention that, my talk today could not even cover all of the good solutions that we have in Parkinson's disease management. And so as that last question, I think, pointed out, there's other issues that can come up that I didn't mention today. And we have very good ways of adjusting your medications and treatment to improve your symptoms. So I think always keeping in close touch with your movement disorders neurologist to come up with the best treatment plan for you is always a great option. And then final plug for regular exercise. So I hope that everybody finds a great way to keep up with exercise, even during these cold winter months.
Great. And thank you so much, Dr. Kim. I appreciate your time today. I appreciate all the folks who joined us from Connecticut, New England, and beyond. This was a wonderful presentation. I want to say again, this program was archived and will be saved on our YouTube channel. And if we did not get to your question, please do call our Parkinson's helpline at 1-800-4PD-INFO. We would be happy to help you. I also want to say another round of applause and thank you to today's sponsors. You can learn more about today's sponsors by visiting our virtual exhibit hall at parkinson.org/New England/chapter supporters. And we hope that you will come back soon. Next up in PD Health at Home on Wellness Wednesday, December 16th, we'll be discussing supportive and palliative care, the best kept secret in medicine. For a complete lineup of our PD Health at Home virtual programs, please visit parkinson.org/PD Health. Now, while we have lots in the works for the new year in New England, our next confirmed virtual program is Exercise in Parkinson's, a topic we talked a little bit about today, and I know many folks would like to hear more on March 23rd with Dr. Mary Feldman of Dartmouth Hitchcock. To pre-register for that program, it's not online yet. You can email me at mmclaughlin@parkinson.org. And that just about wraps us up, folks. In the coming days, you'll receive a short survey. We hope you'll take a minute to complete it. We'd love to get your feedback and hear more about other topics you'd be interested in hearing about. And on behalf of the Parkinson's Foundation, I want to thank you again for joining us. I want to thank Dr. Kim and Yale for tuning in today and making this program possible. Have a safe and happy holiday season and come back soon. Bye, everyone.